Hello everyone, myself Dr. Devanjan Mandal. I'm a physical therapist. Today we are going to do clinical examination for the cervical spine. So before going to start, we should discuss few things about cervical spine. It is an area in which stability has been compromised for mobility, making the cervical spine more vulnerable to injury because it sits between a heavy head and a stable thoracic spine. So first we will check the range of motion. First start with the flexion. So just try to make a double chin or take your chin towards the Adam's apple. Normally it should be pain free, but if patient is complaining that this is painful for him, or might be there is some symptom like sharp shooting pain which is starting from the neck going to the shoulder, or some tingling sensation in the feet, or some nausea kind of sensation, that means there is some serious pathology in the cervical spine. It might be meningitis, it might be some tumor, or it might be a fracture on C2 odontoid or dens. So we have to figure out all this. Next, just try to take your chin on the chest. Two fingers we can consider as normal. Normally this much range should be there. If it is not going that much, that means there is some restriction is there. It might be some muscle tightness on the neck extensor muscles. The range of the neck flexion should be like 80 to 90 degree. And while doing this movement, we have to check the patient if there is any knot-like structure on the spinous process of the C2. If it is not there, it is fine. But if we find that there is some knot-like of structure over there, that means it could be a subluxation of C1 vertebrae on C2. So confirm that, we have to do a test which is known as subpressor test, which we will discuss later on this stage. Next, we are going to check the cervical extension. Take your chin towards the ceiling. Normally the nose and forehead should be parallel to the ceiling, and this range should be like 70 degree. While doing this, if patient is complaining that there is some tingling sensation in the feet, or there is some balance issue, or cord compression, or some drop attack is there, so that is a symptom that there might be some spinal cord compression or vertebrobasilar artery dysfunction. Next, we will check a side flexion. Try to take your ear towards the shoulder. This range should be like 20 to 45 degree on both the side. We have to check. While doing this, sometimes if patient had a lot of tightness on the neck side flexor muscles, what they're trying to do, they're just trying to lift their shoulder to compensate the range of motion. So while doing this test, we should check this one, that patient should not do this kind of movement. Next, we are going to check the rotation. Normally it should be like 70 to 90 degree. Both the side we have to check, right and left. If it is not going much more than 40 to 50 degree, that means there is a problem in C1, C2 vertebrae, because most of the rotational movement is happening on C1, C2 vertebrae, which we call Atlanto-axial joint, which is mainly responsible for the no movement. So this is called no movement. And the Atlanto-occipital joint is mainly responsible for yes movement. We're going to check the passive range of motion. If the patient is not be able to move his head, whatever reason it might be there, that time we have to tell our patient to lie down in supine lying position. In supine lying position, patient range of motion got increase in each and every direction, like flexion, extension, side flexion and rotation also. Like an example, when patient is normally sitting and doing side flexion, the side flexion range of motion like 45 degree. But the same thing, the same patient, if he or she lying down in supine lying position, that time if they are going to do the side flexion, it can go up to 75 to 80 degree. Just because of those muscles got relaxed and they are not working against gravity, that's why we can gain this much range of motion. So that's why when we are doing the upper limb tension test, the last component is neck contralateral side flexion or neck opposite side flexion. So if we are going to perform those kind of tests in sitting position or standing position, we are not gonna get that much range of motion, which we generally get in supine lying position. So that's why all the upper limb tension tests we should perform in supine lying position, because here we are getting more range of motion, so that all the nerves like median nerve, ulnar nerve or radial nerve, we can stretch more. So that is the main benefit in supine lying position doing the ULTT 1, 2 and 3, 4. Now we are going to check the rotation movement of C0 and C1 vertebrae. So to do that, first we have to palpate the mastoid process. So mastoid process is just behind the earlobe. If somebody is not able to palpate that easily, the easiest option is just try to rotate head to the opposite side and tell the patient to push my hand through his head. Then the sternocleidomastoid muscle pop up. Just palpate that muscle. It's a big muscle. We can't miss this muscle. So just palpate that muscle and go a little bit upward. So here is the mastoid process. Go to the neutral position. Relax. Just beneath the mastoid process, we have to go little bit down and little bit anteriorly. Just behind the earlobe, where we can feel little bit bump or bony prominent area, which is the transverse process of C1. Is it painful? So bit careful while palpating the transverse process of C1 because it is bit tender. After getting that, we have to place our thumb just behind the transverse process of C1. Same thing we have to do the opposite side. Behind the earlobe, we can find out the transverse process of C1. Now what do we have to do to check the rotation? We have to tell the patient to rotate the head right and then left. While patient is moving the head on the right side, we will feel the transverse process of C1 more prominent on left side, and right side we will feel that transverse process is becoming disappearing. Now the move opposite side. While moving the head to the left side, right side transverse process is more prominent and left side is like disappearing. So if this appearing and disappearing phenomenon is there, that means the rotation is fine, joint is normal. But if while doing this rotation, if we don't feel that this appearance and disappearance is not there, that means there is a problem on C0 and C1 vertebrae. It might be not moving that much. There is some hypomobility on the joint. Next, we are going to check the rotational movement on C1 and C2, which is also known as Atlanto-axial joint. So again the same thing we have to do. First we have to palpate the mastoid process, which is just behind the ear. Here it is. Then we have to go a little bit down. Behind the earlobe, we can palpate the transverse process of C1. We have to go a little bit further down and a little bit anteriorly. Or we can say, like, if we go behind the jawline, we can find the transverse process of C2. It will be little bit anteriorly just because of the lordotic curvature of the cervical spine. So now I am pressing my thumb just behind the transverse process of C2, and this side, relax, this side I am going to place my thumb on the transverse process of C1. So my right thumb is on the C2 transverse process and left thumb is on the C1 transverse process. Now we are going to do the same movement. Rotate your head to the left side. Again, opposite side. Move your head to the left side. While moving the head on the left side, the C2 transverse process will be more prominent. And opposite thing happen on the C1 transverse process. Like while moving the left side, C2 transverse process will be more prominent and C1 transverse process will be less prominent. While doing the opposite movement, when I am taking the head to the right side, C1 transverse process is more prominent and C2 transverse process is less prominent. We can use this mobilization technique patient who have severe migraine or headache or vertigo type of condition, for them we can use this technique. This is coming under movement with mobilization. So what we are trying to do, when we are rotating the head, we are pressing the transverse forces of C1. When we are taking the right side, we are pressing the transverse forces of C1. When we are moving the head to the left side, we are pressing the transverse forces of C2, so that the rotational movement should be there, because we know that C1 and C2 is mainly responsible for rotation. Most of the rotational movement, like 40 to 50 degree, happen on this Atlanto-axial joint, and transverse ligament is a very important ligament which we will discuss on later in this stage. So if there is some issue on the C1 level, the headache should be like on the top of the head and base of the skull over this area. And if there is issue on C2 vertebrae, the break for pain will be on temporal bone or temporal area.